Good evening. Yes, good evening everyone. Hi Avni, Sarah, Stuti, Roshni and Isha. Good evening everyone. Good evening. Hope you are all doing well, studying well. Am I audible? Yes. So the topic that we are discussing today is renal transplantation. Renal transplant. Okay. So let us understand a few concepts about renal transplant, a few important facts about renal transplant. Why is renal transplant an important topic? Because considering the very much famous and very much popular transplant programs running in the country and worldwide, renal transplant is particularly the most commonly done transplant, and it is very popular. The results are outstanding. So renal transplant is not something a very miraculous surgery nowadays. It's a very routine surgery, and it's a savior to many patients who have a miserable life owing to chronic and regular hemodialysis. So therefore renal transplant becomes a very important topic. Moreover, when we talk about academics, you are recently getting more and more questions on transplants, particularly renal transplant in the recent exams, particularly those of central institutes. So as combined, these questions are going to appear in your INI-CET mostly. So you need to be prepared for these questions as well. Okay. So let us start with a few important facts about renal transplant. So the first living donor renal transplant was performed by Mr. Joe Murray or Joseph Murray in 1954. It was so early that the renal transplant was started. It was done between identical twins. Okay. There is one solution which is known as UW solution, which is University of Wisconsin solution. University of Wisconsin solution. It is an organ preservation solution. Organ preservation solution. And it was discovered by Belzer. Okay. And one more important fact, HLA system was discovered by Dorset. HLA system was discovered by Dorset. Okay. So these are a few important facts about renal transplant and the history, how things went upon. Now it is very important to understand that though renal transplant is a very robust program worldwide, it's not very easy. It's not that easy. We cannot simply take out kidney from one person and simply place it into another person. Why? Because the body has its own defense mechanisms. It resists other tissues. It resists organs coming from the other body, because there are two levels of main barriers which act in this scenario. First is the ABO system that we all know, the blood groups A, B and O. And second is the HLA system. ABO compatibility has to be matched before the transplant, as well as the HLA compatibility has to be matched before the transplant. So ABO compatibility you know very well. Similarly how blood groups are matched, in that way we match the ABO compatibility before the transplant. Coming to HLA, which is important. So HLA matching, to understand HLA matching, let us understand what are the types of HLA. HLA, or you can call MHC. This is type 1 and type 2 HLAs. Type 1 are HLA A, B and C. Type 2 are DR, DP and DQ. Type 1 HLAs have structure of heavy chain plus beta 2 microglobulin, whereas type 2 HLA antigens have alpha plus beta chain. Okay. Type 1 HLA antigens are present on all nucleated cells. All nucleated cells. And these type 2 are present mainly on B cells, dendritic cells, etc. You all know this very well. You must have learned this in microbiology and pathology as well. But this is just for revision, because Bailey has mentioned and described renal transplant particularly in very much detail. So you need to know good details about HLA and MHC. Okay. So this is about HLA and MHC. So despite of doing all the efforts, despite of giving all the efforts, matching the ABO, matching HLAs, despite of doing all this, rejections may occur. What are rejections? Rejection is a reaction which occurs between the graft, that means between the new kidney and the host tissue, and the rejection occurs because the tissue is rejected by the body due to some inflammatory mediators or inflammatory cells. So there are different types of rejection. The first type of rejection is hyperacute rejection. Hyperacute rejection. What is hyperacute rejection? The name itself suggests hyperacute rejection. So it occurs immediately after transplant. It occurs immediately after transplant. It occurs on the table. It occurs on the table itself. So Jesse, I start anastomosis. I start anastomosing the artery and vessels, and immediately the color of the kidney, color of the transplant kidney turns blue. It turns bluish black. So you know that there is hyperacute rejection occurring immediately within seconds. So how does this hyperacute rejection occur? Itna fast kaun kaam karega? Because there are probably preformed antibodies. It occurs due to preformed antibodies. And where have these preformed antibodies come from? They are probably due to prior blood transfusion or prior pregnancy which had occurred, or prior failed transplant. Okay, so there must be already some antigen exposure. Because of this antigen exposure, probably the antibodies have been formed earlier, and now these are causing hyperacute rejection because the antibodies are ready-made antibodies. Okay, so this is hyperacute rejection. Classically, you can see intravascular thrombosis and interstitial hemorrhage in case of intravascular thrombosis and interstitial hemorrhage in case of hyperacute rejection. Okay. Second is acute rejection. Acute rejection. What is acute rejection? It occurs within 6 months of transplant. Within 6 months of kidney transplant. And what is the characteristic? They are characterized by C4D complement deposition. C4D complement deposition in graft microvasculature. Graft microvasculature. C4D complement deposition in graft microvasculature. And they can be T cell mediated or antibody mediated, both. So it can be both. Okay. So far we have learned about hyperacute rejection and acute rejection. Okay. And third type is chronic rejection. Third type is chronic rejection. And how do you define chronic rejection? Chronic rejection is rejection which occurs after 6 months of transplant. After 6 months of transplant. And it is the most common type of rejection. Most common type of rejection. Okay. And what are the characteristics of of chronic rejection? It is characterized by myointimal proliferation. Myointimal proliferation of the vasculature. So if there is myointimal proliferation of the vasculature over a period of time, what will happen? The vasculature will become narrowed. So narrowing of the vasculature will naturally cause fibrosis. So therefore it can lead to glomerular sclerosis. That means fibrosis. And due to lack of blood supply, it can lead to tubular atrophy. Tubular atrophy. Okay. So this is chronic rejection. Okay. So myointimal proliferation leading to decreased blood supply, which can lead to fibrosis or glomerular sclerosis and tubular atrophy. So that is chronic rejection. So to avoid this rejection, what we do is we do HLA matching prior to transplant. HLA matching prior to transplant. And we match HLA at 3 loci. We know there are 6 loci for HLA, right? 6 total antigenic loci, A, B, C and DR, DP, DQ. Class 1 and class 2. We know that, right? So what are the HLAs that we try to match before transplant? We match HLA A, B and DR. Okay. So what is the order of sequence? Order of sequence or order of significance? Order of significance of HLA match is HLA DR more than B more than A. So that means which is the most important HLA to be matched before transplant? DR. This is the most important HLA match to be done before renal transplant. So HLA DR first, then HLA B comes, then HLA A. Okay. There is a nomenclature to define what is matched and what has been mismatched. So when you try to match 3 loci, it may happen sometimes that everything may be matched. It may happen sometimes that everything may be mismatched. So how do you define it? So suppose I say it is a 0-0-0 mismatch. What does that mean? If it is a 0-0-0 mismatch, that means that it is a total match or complete match at all 3 loci. At all 3 loci. Now one important question that you may get is one potential question. For example, I have said that it is 0-1-2 mismatch. What does that mean? You are likely to get this question, particularly in INI-CETs. So what does 0-1-2 mismatch mean? 0-1-2 mismatch means यहाँ पर जो है there is 0 mismatch. That means this is completely matched. Here at this locus there is one mismatch and here there are both mismatches. Okay. So ये वाला locus कौन सा है? This is A, this is B and this is DR. Okay. Please try to understand the order of significance of match is Dr more than B more than A. Okay, so Dr is the most important match. But when you write in a particular nomenclature, the first locus which is written is A, the second locus which is written is B, and the third locus which is written is Dr. So what does 0-1-2 mismatch mean? 0-1-2 mismatch means that there is complete match at locus A, there is one mismatch at B, and both mismatches at Dr. Okay, this is a very important point to understand and remember. Okay, so in order to avoid these mismatches, in order to avoid rejection, what we do is, first of all, we try to match everything. We try to match ABO and HLA. But despite of this, suppose there is some mismatch. Suppose there is one locus mismatch. What do you do? Or even if it is completely matched, you cannot take chances of rejection because you are doing such an important surgery. You are taking out kidney from one person, making him a chronic kidney disease patient for lifetime. You are leaving one patient on one single kidney and giving that vital kidney to another. So you cannot take chances. So these patients, to prevent rejection, have to be on chronic immunosuppression. Okay. So what chronic immunosuppression regimen do we use for renal transplant? For renal transplant, we classically use the triple regimen. The classic triple regimen, which consists of calcineurin inhibitors plus anti-proliferative agents plus steroids. Okay. What are calcineurin inhibitors? Example, cyclosporin or tacrolimus. What are anti-proliferative agents? Azathioprine or mycophenolate. And steroids. Okay, so you have to choose either of these two, cyclosporin or tacrolimus. Tacrolimus is more popular. Azathioprine or mycophenolate, both are used. Either of the two can be used, and steroids. So one of these plus steroids. So that is our standard triple regimen of immunosuppression. Okay, what question do you get on it? The most important thing to understand is mTOR inhibitors are not a part of the standard triple regimen. What are examples of mTOR inhibitors? Yes, sirolimus or everolimus. This is important because sometimes when you get questions randomly, when you have so much burden in your exam, when you are in stress of the exam, you get confused between sirolimus and tacrolimus. Okay, so don't get confused between this. Tacrolimus is calcineurin inhibitor, sirolimus, everolimus are mTOR inhibitors. Though they sound similar, the mechanism of action is different, the category is different. Okay, so therefore this is a vitally important question which is often asked in exams. All of the following are components of standard triple regimen for renal transplant immunosuppression except, and you get tacrolimus, mycophenolate, steroid and sirolimus. Like in options, you have to choose sirolimus as an except. Okay? Yeah. So let us come to organ donation. organ donation. So organ donation can be of two types. The donor can be a live donor, or it can be a deceased donor. Okay, either a live donor or a deceased donor. So if it is a live donor, we call it living donor kidney transplant. And if it is a deceased donor, we call it as cadaveric kidney transplant. Okay. So what is a deceased donor? Deceased donor can be of two types. It can be DBD or it can be DCD. What is DBD? That means deceased after brain death. So he is deceased after brain death, and DCD means he is deceased due to cardiac death. Okay, so disease after brain death or deceased after cardiac death. You know how do you define disease after brain death, or how do you define brain death? Basically in brain death you have to see three things. The first important thing is absence of spontaneous respiration. Second is absence of cranial reflexes. And you check for absent motor response. So there are different criteria you may have learned in FMT basically. So in FMT this is discussed in detail in forensic medicine. So in brain death we mainly see absence of all these three. Spontaneous respiration should not be there. There should be no cranial reflexes and there should be no motor response. And how do you define cardiac death? There is one important classification for cardiac death. So DCD, that is deceased after cardiac death, has been classified as per the Maastricht classification. Okay. So what is Maastricht classification? As per Maastricht classification, category 1 is dead on arrival at the hospital. Okay, dead on arrival at the hospital. Category 2 is when you attempt resuscitation attempted, resuscitation has been attempted but failed. Okay, resuscitation has been attempted but failed. Third is awaiting cardiac arrest. This is important. This is quite frequently asked. Third point. So according to Maastricht classification, category number 3 is awaiting cardiac arrest after withdrawal of support. So the patient is on cardiac arrest, he is on terminal life care support, he is on DOPA, NORAD and whatnot, and he is awaiting cardiac arrest. Once you remove the support, the patient is probably going to arrest. Okay, so that is awaiting cardiac arrest, and that is 3. Okay. So what is 4? Fourth is cardiac arrest when already DBD, when already brain dead. Okay, so cardiac arrest when he is already brain dead. Okay, and what is 5? Cardiac arrest after unsuccessful resuscitation in the hospital. Okay. So this is Maastricht classification. Though not frequently asked, there was one question on Maastricht classification. The question was simple, asked a few years ago in one of the Central Institute exams, that in renal transplant recipients or while choosing renal transplant donors, we choose deceased patients after cardiac death according to which classification? So the answer was Maastricht classification. You may get questions on details of classification. Just remember this: awaiting cardiac arrest. Awaiting cardiac arrest is 3. Okay, this is the most important thing to remember. Okay, I hope you got this, and I can remove this slide now. Yeah. So there is one more category which is known as marginal donor. What is a marginal donor? Suppose you get donors, right? You get calls for because we have a long list of recipients waiting, and you get supposed a deceased donor which is lying in some hospital which is registered for transplant, and you get a call that there is one prospective donor but he is brain dead. Now you have to check whether this is an optimum donor or it's a marginal donor. How do you define marginal donor? In margin, we have defined this marginal donor because we have to explain to the recipient that if you take kidney from this donor, your results may be marginal. You may not get optimum results. You may not get best of the results if you use marginal donor. So the patient has a choice whether to accept kidney from this marginal donor, yes or no. Okay. So you have to tell the patient. So what is marginal donor? Basically, either he has age more than 60 years or age 50 to 60 years with any of the following 2 things. First thing is, when the patient already has hypertension, when the patient is brain dead due to stroke, or when the terminal serum creatinine is more than 1.5 mg per dl. Okay, creatinine of 1.5 millimoles per liter is 132 millimoles per liter. In Western countries, they use this unit, millimoles per liter. So you need to know this also. Okay. So either of these, if the age is between 50 to 6 years, either of these 2 criteria if fulfilled, that is also known as marginal donor. So what is the definition of marginal donor? Either age of more than 60, he goes into marginal donor, or 50 to 60 years plus, either he has hypertension or brain dead due to stroke, or he has a terminal creatinine of more than 1.5 mg per dl, or which is equivalent to 132 millimoles per liter. Okay, so that is defined as marginal donor. There is a criteria which defines or contraindicates organ donation. So what is contraindication for? What are the contraindications for organ donation? Contraindications for organ donation. First is severe HIV particularly severe, hepatitis B, CJD, that is Creutzfeldt-Jakob disease, you know that, Creutzfeldt-Jakob disease, when there is an active infection within the body, and lastly history of malignancy in last 5 years, history of malignancy in last 5 years, except. This except is very important. Whenever there is except, remember dear students, whenever there is except, there is a potential MCQ. Okay, you have to know the red flags, you have to know the red buttons. I always tell in my class, कि एक पॉपुलर मूवी सीन है मूवी धमाल में का, जिसमें एक हवाई जहाज उड़ा रहा होता है, ही इज ड्राइविंग एन एरोप्लेन एंड ये जो इंस्ट्रक्टर होता है ये बोलता है कि लाल बटन दिख रहा है क्या, लाल बटन दिख रहा है, तो वो दबा देते हैं और ये बाद में बोलता है अरे लाल बटन तो नहीं दबाना था। ऐसे ही लाल बटन्स दिए जाते हैं आपको एग्जाम में, दीज आर वेरी ल्यूक्रेटिव ऑप्शंस, आपको ऐसा लगता है कि दीज आर द आंसर्स बट दे आर एक्चुअली नॉट। So these are the red flag signs or red buttons which I always tell in exam, जिसमें भी not होता है, like जैसे मैंने बताया sirolimus is not a component of the triple regimen. So such questions are very important, such points are very important, such clues are very important. So here also red button. History of malignancy in last 5 years is a contraindication, but what is not a contraindication is primary CNS tumor, because it is less likely to metastasize into the kidney. Carcinoma in situ of cervix, carcinoma in situ of cervix and non-melanotic skin carcinomas. So melanoma is a contraindication, but if you take squamous cell carcinoma, it is not a contraindication. If it's a squamous cell carcinoma of the skin, it is not a contraindication. Okay, so these are very important points. Okay, I hope this is taken down well. Cold ischemia time. Cold ischemia time. Till what time can you store the kidney? Cold ischemia time or storage time, cold storage time. The optimum time for kidney, I am talking about kidney, we are talking about kidney transplant. The optimum time should be less than 18 hours. Different books have different values, but as per your Bailey, it is 18 hours for the kidney optimum time, and maximum time permissible is less than 36 hours, double. Okay, so optimum is less than 18 hours and maximum is 36 hours. Okay, now coming to surgical aspects of kidney transplant. Surgical aspects of kidney transplant. So in kidney transplant, suppose you are given a choice, which kidney is preferred for organ donation. Suppose you have a live donor. Okay, so while we investigate a live donor, suppose he is in relation, he is a brother, he is or a sister who wants to donate to brother or sister. Now you have to evaluate the donor first. You have to do a scan, you have to do a renal scan, check the percentage function of the kidney. Normally, if the kidneys are not equally functional, the better functioning kidney, suppose the kidney function is 60% and 40%, the 60%, that is better functioning kidney, remains with the donor. The donor is not made another transplant recipient. Donor को फिर से transplant के लिए नहीं लेके जाना है, ठीक है? So the better functioning kidney remains with the donor and the lesser functioning kidney goes to the recipient. But if you have a choice, suppose normal patients may, in most of the scenarios, you get equally functional kidneys, almost equally functional kidneys. So अगर ऐसा है, then which kidney will you prefer for harvesting to do a renal transplant? Donor की कौन सी kidney choose करेंगे? Yes, left या right? The left kidney of the donor, left kidney of donor is preferred. Left kidney of donor is preferred for renal transplant. And why is the left kidney preferred? Yes, the left kidney is preferred because it has a longer renal vein. Basics. Yes, we know that left kidney has a long renal vein. This is right kidney, this is left kidney. This is IVC and this is aorta. So if you talk about vein, naturally the right renal vein will be small and the left renal vein will be long, because it has to cross the midline, go on the opposite side and drain into the IVC. So therefore the left renal vein is long, and therefore this left kidney is preferred for renal transplant. But why are we concerned about renal vein only? लंबी vein क्यों चाहिए हमें? Why do we want renal vein long? Because when we place transplant, when we place the transplanted kidney, we place it in the iliac fossa. Transplanted kidney कहाँ डाली जाती है? Iliac fossa में. सब iliac fossa में जब डालते हैं आप, when you anastomose the renal arteries and renal vein with the vessels, with the iliac vessels, the iliac vein particularly is in deep position. So when you place a kidney like this, the iliac vessels are already deep. The artery is little bit superficial. The artery is quite superficial, but the vein is quite deep. So if you want to place a kidney like this, the artery will be easily anastomosed, but the vein has to be longer because it has to go deep to reach up to the iliac vessels, up to the iliac vein. Up to the iliac vein it has to reach. इसलिए ये लंबी होनी चाहिए. And veins are particularly of thin musculature, thin walled. So वो anastomosis के वक्त tear नहीं होनी चाहिए. It should not get teared off. It should not come under traction while we do anastomosis. It should be very loose. Okay. So that is why we need a longer renal vein, because of this anatomical difficulties. Okay. So that is why left kidney is preferred for renal transplant. Right. So where is the transplant kidney placed? The transplant kidney is placed in the iliac fossa. Is placed in the iliac fossa extraperitoneally. Extraperitoneally. It is extraperitoneally placed. Okay. What incision do we take for renal transplant? Yes. So suppose this is the abdomen and this is the pubic symphysis. Okay. This is symphysis pubis. What incision do we take for renal transplant? What is it called? It is something like this, which is a classical Gibson's incision. This is known as Gibson's incision. Or what we do nowadays is take a little bit curvilinear incision like this, which is a little bit hockey stick like incision, which is known as modified Gibson's incision. Modified Gibson's incision, or you can call it hockey stick incision. Okay. So this is the incision which we take for placing kidney into the iliac fossa. Okay. So this is the incision for renal transplant. Now where do we anastomose the vessels? The renal vessels are anastomosed to either external or internal iliac vessels. External or internal iliac vessels. So the renal vessels are anastomosed to the iliac vessels, right? And the ureter is anastomosed to the bladder by, most commonly what technique is used for anastomosis here? It is Lich-Gregoire technique. Lich-Gregoire technique. This is the most commonly used technique. Okay. And what is the sequence of anastomosis? Sequence of anastomosis. How do you anastomose? Artery सबसे पहले anastomose करते हैं या vein या ureter? How do you anastomose it? The sequence of anastomosis is very important. First of all, we anastomose the vein, then artery, and lastly ureter. Okay. First we anastomose the vein, then artery, and then the ureter. This is how we anastomose the kidney. And why is this sequence so? Why can't we anastomose the artery first? Suppose you anastomose the artery and you open up the artery, you leave the artery open. What will happen? The kidney will get congested. So you cannot release the venous clamp. If you don't release the venous clamp, what will happen? If you don't release the venous clamp, the kidney will get congested because the inflow is there, but there is no outflow. If you release the clamp, what will happen? There will be so much of blood that you won't be able to perform anastomosis. So first of all, you have to perform venous anastomosis and release the venous clamp, and then immediately perform the arterial anastomosis so that as early as possible you can declamp the kidney. So anastomosing vein first and artery next reduces the ischemia time. It saves the clamping time. Okay, so that is why vein first, then artery, and lastly ureter. Ureter is not an emergency to anastomose. Okay, and lastly, one more important point. In case of children, particularly which are small, less than 2 years particularly, there is no space in the iliac fossa for kidney to accommodate. So here the renal vessels are anastomosed to aorta and IVC directly. Aorta and IVC directly, and the kidney is placed intraperitoneally. In case of children, the kidney is placed intraperitoneally. Okay. So this is how we conclude the renal transplant topic. So this is a short topic but very important topic, and you can get questions particularly pertaining to the HLA matches. You can get questions like which of the following are HLA matched before transplant except. So you'll get options like HLA, DR, DP, A and B. So here DP goes in except. So we know that HLA A match is there, HLA B matching is done, HLA DR is done. DR is the most important match, right? You can get questions on rejection like C4D complement deposition is seen in which type of rejection. So the answer would be acute rejection, right? You can get questions like particularly like which is the most common type of rejection. So it is chronic rejection, which is the most common type, right? You can get questions on matching like 0-1-2 mismatch. What is the 0-1-2 mismatch? There is a complete mismatch at which locus? So you know that it is at the DR position. So DR is completely mismatched if it is a 0-1-2 mismatch. Okay. You may get questions pertaining to marginal donor, definition of marginal donor. You can get question pertaining to Maastricht classification, which is in DCD donors. You can get questions on this surgical aspect, basic surgical aspect. Okay. So this is how kidney transplant topic is being covered. So this is how we cover lectures in live classes in the DAMS app, the ultimate live course app that we have launched this year. And hopefully you're finding this very interactive. Side by side, I can answer your questions. Once the topic is done, I can answer your questions, as I can see in my live chat. I can see all your responses, all your questions, all your queries. So someone wants the initial slides. So these are the initial slides. Arindam is asking why in children intraperitoneal and adult extraperitoneal. So in adults, we are placing it extraperitoneal because kidneys are meant to be extraperitoneal, right? It's the physiological aspect. So kidneys placed here. We don't remove the native kidneys. Native kidneys basically we place a third kidney when we do a transplant, right? But in children, there is no space in the extraperitoneal. There is no space in the right iliac fossa extraperitoneally. Therefore, it is placed intraperitoneally. Okay. Okay. So you can subscribe to this DAMS live course, and particularly if you want some discount, I have a referral code for you. That is DRVI Med 881. Okay, so this will straight away give you 10% discount. That's what information I've got from the head office. And so someone wants the DCD DBD classification side. Okay. Yeah, it is here. Sana is asking why vein first and then artery. But a vein, when we do artery, if we do artery anastomosis first, and if we release the clamp, what will happen? The artery will start flowing into the kidney, right? The starting will start gushing blood into the kidney. But you haven't anastomosed its vein yet. So inflow to chalu ho gaya, but what about outflow? If there is only inflow within the kidney will get congested and will start bleeding, right? So therefore you have to anastomose the outlet first. Outlet चालू नहीं करेंगे तो inlet नहीं चालू करना चाहिए, right? Aishwarya is asking what is the clamping time? No, it is. It depends on the anastomosis. As I've told you, whenever you get kidney from a donor, you freeze it. Okay, you keep it in ice. You irrigate it with a cold University of Wisconsin solution or HTK solution. There's another solution, organ preserving solution. So either of the two solutions, the kidney is kept in and it is frozen. Okay, so that the cold ischemia time is used. And if the kidney is frozen, you can use it up to very long time, right? 18 hours or so. But if we do a live donor, we do it immediately. Once we get harvested, we immediately transplant it into other kidney. So when we do a live donor, we simultaneously, two urologists operate in two OTs side by side. One surgeon, one of my colleague operates in the donor OT. So he harvests the kidney, and meanwhile I get the recipient ready. I expose the iliac vessels, I keep the ureter, I keep the bladder dissected, I keep the bladder ready, I keep the iliac vessels ready for anastomosis. So as soon as I get the kidney, I flush it with the irrigant solution and immediately start anastomosis. So it takes hardly 20 to 25 minutes for the transplant to perform once the kidney is in my hand. Harshita is asking why don't we remove the deceased kidney? Because the deceased kidney there are certain indications to remove the deceased kidney. If the two native kidneys are shrunken small, they are not causing any harm. We do know they are non-functional, but they are not causing harm. Why to perform an additional surgery for the same? Okay. Do you perform appendicectomy for every patient even if there is no appendicitis? No. Similarly, the kidneys, even if they are non-functional, as long as they are not causing any harm to the body, they are not removed, right? So we place a third kidney when we do renal transplant. Chawla is asking what incision is given to the donor. The donor nephrectomy can be performed by open surgery, by a flank incision, by a trans 11th rib cutting incision, or it can be performed laparoscopically or robotically. So when we do laparoscopy or robotic harvestation of the donor kidney, we take a Fannin steel incision and deliver kidney from there. Okay, someone wants one more rejection slide. That is the rejection slide. Okay. So thank you everyone. So this was a session for renal transplant. Doubts are always welcome. I am always available on the club. We all teachers are available on the DAMS club. Whatever doubts you have, you can post them there. We can answer them separately. We are also available on Messenger. You can ask on the club also. You can ask publicly. You can ask personally on the Messenger. You can ask on email ID also. My email ID is Vivek Urologist @yahoo.com. So take particular advantage of whatever knowledge I have. After my MS in general surgery, I have done MCH in urology. So that's been a super specialization, and I practice only and only urology alone, that is genitourinary surgery. So whatever doubts you have regarding concepts, basically. So urology, if I teach in my lecture, you would come to know that it's basically a conceptual subject. Basically surgery is a most like conceptual subject. What you rather know that surgery में सिर्फ काटा छाटी होती है, काटना है नहीं काटना है, ऐसा नहीं होता है. You need to understand concepts in surgery, and here I am there to clear your concepts in genitourinary surgery, that is urology in toto. So I teach here kidney, bladder, prostate, ureter, testes, urethra, penis, transplant and trauma. So everything in urology is covered by me in DAMS. Okay. So thank you everyone. I'll take your leave now. Thank you.